Jenkins, and I'm one of Tom's supervisors at the University of Bath, along with Paul Chadwick. So yeah, very pleased to be introducing Tom today, who's now in the third year of his PhD, and he's going to tell you a bit about his work in developing a new assessment scale to look at experiences of dehumanization in people with psychosis. So over to you, Tom.
Thank you, Tom.
Hello, is that working now? Oh, fantastic. Okay. Hello. Okay, sorry about that. I'm here. Yeah, so the talk I'm going to give today is about the role that people with lived experience of psychosis have played in helping us developing the dehumanization in psychosis scale. This is currently a paper that we're writing, so I'm going to talk to you a little bit about that, and then indirectly also explain some of the methods that we've been using recently. So self-dehumanization is when a person feels less or other than human. People with psychosis are not only perceived and treated as less human than other people, as shown by some of the literature, but also people with psychosis talk about feeling dehumanized. And in part, this is due to the stigma and the stereotypes surrounding the condition, but also the nature of the condition. So the experience of hearing voices or the experience of paranoia can sometimes really make people feel different to those around them. So we knew about this through clinical work. We wanted to begin to look at self-dehumanization as a treatment target for therapy for psychosis. But once we began looking through the literature, we couldn't really find a great way in which to measure it. So that's become the focus of the PhD. And we wanted to begin by sort of conceptualizing self-dehumanization. So firstly, we looked into the literature to try and look for a definition of self-dehumanization. And we also spoke to people with experience of psychosis in a qualitative study about their experiences of self-dehumanization. And this slide, I want to highlight the sort of benefits of doing this kind of work qualitatively, as well as through looking through the literature. So once we looked through the literature, we found that personal agency, sense of belonging, and sense of worth were all really important parts of what make people feel human, but also less than human. And these were also echoed by the people that we spoke to in the qualitative study. But also, the people that we spoke to in the qualitative study showed us some, or told us about some other experiences that were also very, very dehumanizing for them. So integrity of self as a private and coherent entity. So feeling with psychosis, one's sense of self can become fractured and fragmented, and that sense of identity can become distorted. So that can be very dehumanizing for people. Extent of distressing sensory fragmentation. So one's experience of hearing voices. For example, people have described this as being, as voice hearing being an omnipotent, controlling experience. Others describing it as being like a traumatizing attack. So that kind of intrusion into one's own sensory experience can be incredibly dehumanizing for people. And finally, trust in one's own credibility and reliability. So the feeling of being able to trust oneself, one's thoughts, one's feelings, one's behaviors. Again, all very, very dehumanizing once we start to lose sense of that. So to summarize the slide, the ones in green here show what we found in the literature and by speaking to people with psychosis, but also the ones in yellow are told to us just by people with psychosis. So it shows the sort of benefits of working in this way. And I should have said at the beginning, this was a qualitative study led by Beth, who is a colleague of mine. So with this in mind, this is kind of our theoretical model. So this is the basis from which we begin to develop statements for our questionnaire. When I say items, I mean statements as well. So item generation just means statements. So we wanted to sort of represent each of these domains of experience, each of these 6 categories of experience, with kind of statements or items which reflected them. We did a literature search and we picked out some of the statements already in questionnaires in the literature. We used some of the transcripts from the qualitative interviews I mentioned in the previous slide. And we also did 2 PPI focus groups. So PPI stands for patient and public involvement. We worked with a group of 5 people with lived experience of distressing psychosis and mental health service use. And the first group was all about discussing the relevance of these 6 domains of experience. So we presented the group with what I just showed you on the previous slide, as well as some descriptions around what we meant by this. And we really asked, does this reflect your experience? Do you have feedback to add? Are there things which don't apply? Is there anything you'd like to change? And the group was really the group really agreed with what we had there, and they shared personal anecdotes and stories actually relevant to each of those domains. But the main takeaway from that focus group was that there was nothing more to add to that experience. The second focus group, the purpose of that was to begin generating statements and items which would represent each of those 6 domains. So at the end of this sort of item generation process, we had a list of 59 items, which the PPI group all approved of. And we could then be sure that we had quite a long list of potential things which we could begin to use as the first draft of our questionnaire. We next move into a Delphi study. So a Delphi study is a consensus methodology where we bring together expert stakeholders to come to an agreement on the most important statements to reflect an outcome. So in our case, this is dehumanization. So we brought together people with lived experience of psychosis, with mental health professionals, dehumanization researchers, and carers of people with psychosis. So the purpose here was to get a diverse pool of stakeholders, some professional and some with lived experience as well. So we asked them to rate the importance of those 59 statements for measuring dehumanization. And we set sort of cutoffs. So we set numerical thresholds at which agreement would be decided. And you can see here we did this across 2 rounds. So we began with 59 items. We had some excluded, some re-rated, some amended as well. And we finished off with 25 items. So we could be sure here that those 25 were agreed upon by a diverse group of stakeholders as being important for measuring dehumanization. We next went into some cognitive interviews. So we used here the think aloud method, speaking to people with experience of psychosis. And the cognitive interview is a really great way of getting an understanding of how a person interprets a statement on a questionnaire. So instead of asking somebody to complete a statement, say by saying they agree or they disagree with it, instead, somebody's invited to think aloud and to articulate their thought process as though they were going to answer the statement. So if we have a statement such as, I am the life and soul of a party, instead of me saying slightly disagree, I might say something like, well, I'm thinking about the last time I was at a party, and I'm thinking about how I spoke to my friends and went home at 10 o'clock, so probably not. So it gives you a really good understanding of how is somebody interpreting that statement on the questionnaire, and what is somebody thinking when they're about to answer it. So that kind of feedback then allows us to improve and tweak the wording of certain items and make it hopefully more accurate, but also more understandable for people. And it allows us to remove anything which might be sort of unacceptable or offensive to people as well. Across 3 rounds, we went from 25 items at the beginning. We removed a couple, we amended some, we had one added as well. And then eventually we ended up with 22 items. So just some examples here, just what this looks like. I can go through each of these. So we had one item, which is, I feel dehumanized by my experience of psychosis. The feedback we got here was before this study, I wouldn't know what dehumanized means. And this is a really good piece of feedback. I use that word all the time, but actually it's not commonly used among people. So what we did with that was we just got rid of it. We had several other statements or items which were very similar. I'm more than my psychosis. So the feedback we had for this was, I don't like my psychosis. I don't feel like I own it. Again, this is really good feedback. My psychosis sounds quite permanent, and it sounds like it really defines and belongs to the person. So instead, we went with I am more than my experience of psychosis. Again, painting psychosis as something much more transient. I feel a sense of belonging with other people, and I do not belong with other people. The feedback we had for these was, I don't know who you mean by other people. Some people accept me, but others don't. And again, this is excellent feedback. Other people is quite a vague category. So instead, we went with, I feel a sense of belonging with the people in my life, and I do not belong in society. So the people in my life, getting at those people who we choose to spend our time with, perhaps our friends and our family. And then I do not belong in this society as touching upon that sort of wider sense of belonging that we might have. And finally, then I can't trust my thoughts and feelings. So I don't have feelings, but I have thoughts. These are two different things. And again, this is excellent feedback. Feelings and thoughts are separate. So we changed this to I can't trust my own feelings. And then we had another statement, which is I can't trust my own mind, to represent that cognitive domain. So yeah, in summary, in developing the DIPs, people with lived experience have not only deepened our theoretical understanding of what this concept is, but they've also contributed meaningful, important statements to the questionnaire and improved the wording of the questionnaire. So this has undoubtedly made it better. It's made it more acceptable, and hopefully it's going to make it more accurate when we get to doing the statistical analysis. The clinical implications of this is we hope that the DIPs is going to be a useful outcome measure in therapy for psychosis. So instead of looking at the sort of symptom-based measures that very often are used, instead looking at items such as, does somebody feel like they belong with other people? Does somebody feel like they have agency and control over their lives? And also then for research. So I'm currently working on the final study of my PhD, which is a validation study. So what that is a questionnaire-based study where we give the questionnaire out to lots of different people, along with some other measures of mental health. And we test to see whether or not it's measuring this experience accurately. So whether or not it's measuring self-dehumanization in a way in which we would expect. And that study is currently recruiting across 7 NHS trusts at the moment, with a sample size target of about 200. So yeah, that's my focus for the next 6 months or so. And of course, once we have the measure developed, then there's lots of research questions we can begin to ask, and that one day I hope to answer. So thanks so much for listening. Thanks so much to Pamela and Paul, my 2 brilliant supervisors, my research group at the Bath Centre for Mindfulness and Community, and of course, Mental Health Research UK for all your support, and to you for listening. Thanks.
Thank you.